Well, that was an invigorating weekend, I guess is an understatement. But this morning we have a way to really liven things up and warm everybody up. We have just a wonderful Burchell Lecture coming up for you. And so I want to celebrate the annual Burchell Lecture, which has been going on for 20 years or so. And I was blessed, and so was Mike Mooney and a few others in the room, Chuck Gornick, who have worked with Howard Burchell, for whom this lecture is named. And Howard was a chairman of cardiology at the University of Minnesota, was editor of Circulation. But more importantly, he was a mentor to many of us in this room in that once he retired in his later years, he came over to this hospital and was here for 20 years from age 70 to in his 90s. And he seemed to always know what everyone was interested in research-wise. So if Mike was interested in hypothermia, Howard would be able to talk to him about that. Barry Marin, when he was here, he tells the story of being in the library at the hospital one day and coming across Howard. In 2010, Howard was 91. And Howard was reading about commotio cordis, which Barry had just written a New England Journal of Medicine article on, and was interested in how it worked. And after the conversation, Howard says, "You know, I think I'm going to try this." And he puts his fist up to his chest, and he says, "I've had a long and productive life," and he says, "This might be the way to go." But at any rate, he had a sense of humor. He also was very approachable. His white hair and a gravelly voice that always needed some WD-40. And so we always have a very special guest of honor to celebrate the Burchell Lecture. You see the past lecturers. Last year was Clyde Yancey, very well attended. Matthew Maurer, we had Navin Kapoor, Anne-Marie Valente, Bob Harrington, Carl Papine, Dick Asinger, David Holmes, and Bernie Gersh. And now, this year, we have one of the giants in cardiology, in my opinion, and that's Doug Mann from Washington University in St. Louis. And I thought when he got off the plane last night, he was going to turn around and go home, but they had tornado warning, so he said he was going to stay here.
Yeah, this is between a rock and a hard place, a tornado and a snowstorm, right?
I first became aware of Dr. Mann's research 30-some years ago when I read a paper in Circulation about how norepinephrine causes myocyte injury and cell death, and he worked on elucidating the mechanism of that. And then over his career, he's been chairman of cardiology at Baylor for 10 years, and then was chairman of cardiology at Washington University in St. Louis here until 2019 for 10 years, and he continues to be professor of at the medical school in cell biology and physiology. He wrote a wonderful piece in JACC in 2020 about heart failure and recovered ejection fraction, another acronym that we have. And I thought it was such a great article because it touched all of the subspecialties of cardiology. So I invited Doug to come up and speak to us this morning, and we're just blessed to have you.
So, thank you for the overly kind introduction. It's a real pleasure and honor to be here. I didn't know much about Dr. Burchell, but I did some research before I came up here, and I found this one quote when he was stepping down as editor for Circulation, and I think it captures a lot of what I thought I knew about him. And I'll just read you a little bit about what one of the editors, the incoming editors, wrote about him. He said, "In my view, among Howard's many attributes, several are paramount importance to his successful editorship: his high professional standing, ceaseless striving for perfection," which I think resonates with all of us, and compassion, again, which I think resonates with all of us. And the part I thought was really wonderful was he said, "With a keen mind and persuasive personality, he's continued to use basic science background, not only in unraveling the complexities of clinical cardiology as they apply to the patient, but also in teaching the developing cardiologist." So I think he was probably one of the last people who was a true triple threat, who was a splendid physician, a scholar, teacher, and also investigator. So I'm really honored to be able to honor his memory and talk a little bit about this concept of recovered EF. When we first started doing this, and I presented it at one of the LVAD meetings, I had a lifetime ban, I think, because we came up with this concept that recovery is not what you think it is, and in fact, the heart really probably never does recover, and that was a hard pill to swallow, because we were all sort of brought up in the J. Cone spirit that if you could get the heart to reverse remodel, that you could claim victory. So this is a simple slide just to sort of lay out the talk today. We know that after cardiac injury that the heart will undergo a process known as left ventricular remodeling. Heart gets bigger, walls get thinner. Patients will develop congestive symptomatology. Over the years, the heart failure community, which I've been part of and pleased to be part of and honored to be part of, have developed a number of medical and device therapies. And what we've begun to understand is that in some patients, unfortunately, precious few, you can get a full recovery of left ventricular ejection fraction. These people, many of whom do well. More commonly, we deal with this concept of partial recovery, where the EFs are between 40 to 50%. And these people tend to come back and forth in the hospital, and this is sort of what most of the young doctors are dealing with, the house staff, at least at WashU. And then there's a group of people who really never recover, and these are the people we put in LVADs and do cardiac transplantation on. So my talk this morning will really just sort of focus in on this group of people in whom we're beginning to really understand a lot more about them and how to manage them, although we still have a long way to go. So years ago, I got involved with a group of people on this topic of heart failure with a recovered ejection fraction. And as we dove into the literature, it became really apparent that it was a hot mess. The nomenclature was messy. There were like different titles for it: heart failure improved, heart failure preserved, borderline, recovered, mid-range. It was just a mess. And the definition was entirely unclear. So some people insisted that the EF increased more than 5%. Others increased more than 10%. Some people just said, doesn't matter how much it improves, as long as the EF is greater than 50% or 40%. We really didn't know much about the clinical course, and more importantly for people like me who try to understand the biology of heart failure, we knew very little bit about the biology of it. So I was fortunate enough to work with a really talented group of people: Jane Wilcox, Jim Fang, Ken Margulies. And at the behest of Dr. Fuster, we published this paper on recovered left ventricular ejection fraction and tried to at least put a stake in the ground, say this is a real entity. And at the time, it was unclear. Subsequently, there was a study that showed that we were right in thinking what we were thinking. But it was really unclear. So we kind of staked out some large swaths of territory, probably went well beyond what we knew and what anyone else knew, and still put our nickel down and tried to describe what the thing was. So we came up with the title Heart Failure Recovered EF. It turns out that won't hold up. It'll probably be regarded as heart failure with an improved EF. We felt that it was important that the increase in LVEF be greater than 10%, and I'll show you the rationale for that in a coming up slide. And we felt that there had to be normalization greater than 40%. Just by way of full disclosure, the Europeans think it has to be greater than 50%. And the American guidelines don't really care how much it improves. They just said it has to be less than 40 and then improve to 40. And so I'll kind of walk through what we know about this entity and talk a little bit about the therapy that we know today, but we still need to learn a lot more. So I think the first thing is to understand what ejection fraction measures. When I went to medical school, we were all taught ejection fraction is a measure of contractility. It's actually not really much of a useful index of contractility. What it is a great index of is left ventricular volume, and that's shown on this slide. By virtue of the way that we calculate the ejection fraction, as the end diastolic volume goes up, the EF has to go down. So for me, when I see a low EF, I know I'm dealing with a remodeled ventricle. So these are all LV dilation. And it doesn't matter what the cardiac output was. So as you increase your end diastolic volume, the ejection fraction obligatorily goes down just by virtue of the way that we calculate it. So for me as a heart failure doc, I've always just seen low EF as a dilated ventricle, and I know how to treat that. So what about the epidemiology of heart failure with a recovered EF? When we first started down this road, the LVAD mafia were claiming that this was strictly something that happened if you put a VAD in people and then a certain small percent would get better. You could take the VAD out and they would go home. If you actually look and drill into the literature, you can see that the vast majority of different cardiomyopathies that one can have, many of whom will recover. And Ken Margulies did a wonderful review where he just grouped into 3 groups, so-called toxic insults, inflammation, which we've studied in the lab for years, and then abnormal energetics, including tachycardia-induced heart failure, and then stress cardiomyopathy, which I know Scott has spent a lot of time talking about. The important thing is that all of these entities, the ejection fraction will improve once the underlying condition resolves. This is a paper that I did with Mike Gevertz. And Mike and I went in the entire literature, and this is now a number of years ago, but we went and tried to pull out every single paper that had an improved ejection fraction, and we pulled out 2 different groups of people, those who had improved the EF greater than 10%, and they're shown in the blue bars in the back here, and then those who actually completely normalized left ventricular structure and function. So a couple things fall out of this simple analysis. You can see here that the energetic cardiomyopathies, they are the ones that improve EF by more than 10% and will also completely normalize. So short-term hits to the ventricle tend to do better. The toxins, and today we are good at doing this with chemotherapy. This blue bar here just gives you the range of different ejection fractions that you can have. But you can see here that the toxins, many of whom will recover greater than 10%, and they also normalize their ejection fractions. We've gotten good at understanding when to stop giving chemotherapy. The other group of patients that I've studied a lot are these inflammatory cardiomyopathies, and you can see here, depending on the nature of it, that the ejection fraction will improve anywhere from 40% will have 10% approval to 100% can go back to normal. But because it's longer lasting and there's more collateral damage from the inflammation, about half of these people will completely normalize their ejection fraction. So again, the take-home message here is that once the inciting stress is removed, the ejection fraction improves and patients do better. What about all the drugs that we give as heart failure docs? This slide just summarizes the effect of all FDA-approved therapies on reverse remodeling. And when I talk about reverse remodeling, it's synonymous with the ejection fraction going up. But you can see here that if you give ACE inhibitors, if you give ARBs, if you give spironolactone, you do CRT or LVADs, the ejection fraction comes up. The 2 new kids on the block, for which we have less data, scubitril/valsartan also is associated with reverse remodeling, and then the SGLT2 inhibitors in some studies actually show reverse remodeling. So all of the FDA-approved therapies that we have that make people better, the ejection fraction will go up and the hearts will reverse remodel. So first take-home message is, once the inciting event is removed, recovery of LVF is the rule rather than the exception. This is what got me in trouble with the LVAD mafia. I was banned from the recovery symposia for at least a decade. And then the other thing is that although recovery of EF occurs frequently, the normalization of the ejection fraction varies, and it depends on the nature of the inciting event. And that becomes important when we think about what medicines these people should have and which medicines they can be taken off of. So what about the durability? This is where it became really interesting for me. We had set up a database at WashU. This is in 2009 when the NIH was giving out money and to sort of save the economy. So we just sort of said, we're agnostic about the ejection fraction. What we're really interested in is heart failure. So we collected the data on over 1,000 people, agnostic to EF. We just wanted to make sure they had heart failure. So one of the groups that popped out, and this is when we knew very little about this, the so-called mid-range, there was a resident who wanted a cardiology fellowship. And I said, okay, you need to go back into our registry, again, about 1,000 patients, and pull out these people who have an ejection fraction of 40 to 50%. And then I want you to go in and figure out what their ejection fraction was before it was 40%. So when they were enrolled, that was the ejection fraction they had, but because we had data on all these people. So he went in there and found out that most of the people we had ejection fractions on, most of these people were people who had had a reduced ejection fraction that had gotten better, and so that's not a surprise. There were some that had preserved EFs greater than 50% that had deteriorated, and then there were a very small group of people that had been the same. So this allowed us to tease out the different categories and begin to understand this mid-range EF as really recovered EF, if you will, and then ask them some questions about it. So the first thing that was really, really interesting, if you look at the mid-range EF, most of these are people who recovered, and then the heart failure reduced EF, these people do a lot better. So this is event-free survival, this is death, transplant, or heart failure hospitalization. So responders to medical therapy do better than non-responders. Not a big deal. The really interesting part was when we compared the mid-range EF, again, most of whom had recovered, and then compared them to the preserved EF, you can see they continue to have heart failure events. So this was one of the eye-opening things. They said, oh, even though the ejection fraction gets better, they're still coming into the hospital with heart failure. What's up with that? So, and again, this is before we really understood what we were doing. So we also were able to get some money to do what we call a proteomic survey of all these patients. Again, limited samples, but we took them from the cohort that I just showed you. So we took the registry, we broke them down into the heart failure reduced EF, the heart failure preserved EF, and then this mid-range, most of whom had come from the reduced ejection fraction bucket. And we did aptamer-based proteomic analysis, and I'll explain that on the next slide, and then did a bunch of fancy proteomic bioinformatic analysis. And I'll walk you through this just so it's less magical. So with the aptamers, these are DNA molecules that have been custom designed to bind to proteins. So you can tweak these aptamers so they'll bind to, when we did it, there were 1,000 proteins. Now they're up to 7,000. So you can customize these proteins, these DNA aptamers, to bind to different proteins. You sort of incubate these. The markers have a biotin on them, so you can figure out who they are. And the bottom line is that through a series of steps, you can determine who is bound to these aptamers, and because of the kind of aptamer they're bound to, you can identify the protein. So unfortunately, it doesn't give you a level of a protein like 10 nanograms or 15 picograms, but what it does do is allow you to compare two different proteins. So on the analysis that we did, if there are no differences between the protein, if protein A and protein B have the same level, it'll be gray, all right? If there's an increase in the protein, it'll be red, and if it's blue, it means there's a decrease relative to your control group. So the first thing we did was to just compare heart failure reduced EF versus preserved EF. You can see there's a lot of blue and a lot of red. Not surprising, we think that there are two different flavors of heart failure. We then compared the heart failure reduced EF to the mid-range. Remember, this mid-range is coming from the reduced population. We saw a lot of different proteomic signatures. And I said, oh my God, so it really is a different clinical classification and different biology. And then again, if you remember those Kaplan-Meier curves, when we compared the heart failure mid-range EF versus preserved, they almost have identical Kaplan-Meier curves. You can see that there's a lot of gray and less blue and red. So this allowed us to sort of do what's called a PCA plot. That's where you take all of the proteins and just sort of look at the variability, and you come up with really simple ways of looking at them. So this cloud represents all the proteins that are specific for reduced EF. This cloud is for the preserved EF. And if you'll notice, the mid-range EF is sort of halfway in between the two different things. And then again, this is analysis a little skewed because we didn't have a lot of patients, but we looked at the mid-range who had improved their EF to get into that category and the ones that had stayed the same. And you can see that the ones who hadn't really improved but had sort of in between, they're halfway in between REF and PEF. And then again, this category of the mid-range improved EF, the ones whose EFs had gotten better, remained a distinct biological group of people. So this was really good for us because we had been arguing that it's a different biology and a different group of people, and it's not the same as just people who were normal. So so I've talked a little bit about the durability of that mid-range group. What about people who completely recover their EFs? Are they immune to developing heart failure again? The answer is no. So Jim Fang did a really nice paper. They used the Penn database, and what they did is they went in there and looked at people who had reduced EF, a preserved EF, and then a recovered EF, and they used the same definitions that we did because our databases were identical. Not surprisingly, the people who had reduced EF had the highest amount of cardiac events. This is death, transplant, or VAD. You can see that the preserved is sort of in between, and then the responders, the recovered EFs greater than 50, people who got better on medicines, had the best outcome. This was probably not surprising. What was surprising and looked a lot like our data was that if you just looked at the probability of cardiac hospitalization, again, the reduced, the HEF-REFers have the most hospitalization, but if you see here, the people who recovered in green have the exact same amount of hospitalizations as the people who have the preserved and the recovered are exactly the same. So again, this idea that even though the EF gets better, they still have heart failure events. And so again, this coincided with what we had seen and my idea that at least on the proteomic level, we could define a group of people who were biologically distinct. They just still kept on having heart failure. So there was also a really nice study by Joe Merlo, and these were a group of Italian investigators. They had exquisitely well-phenotyped patients with dilated cardiomyopathy. And so all these people had serial MRIs. They were on state-of-the-art therapy. They went into their database of 400 patients. They found that 15% of the whole group, 15% of their cohort, met a rigorous definition of recovery, EF greater than 50%, and a ventricle that had gotten smaller. Anybody in the heart failure mafia would have said, these guys are recovered. They then followed these patients out for years, and they found out that of this 15%, 60% remained stable over a period of 4 to 5 years, and then the other 40% actually redeveloped heart failure, just like we had seen. And so again, these were ideas that we always had thought if the heart gets better and the ejection fraction goes up, we've cured the heart failure, and this was not the case. So the observation that heart failure recurs in patients whose structure and function completely normalized was irreconcilable with everything that I thought I knew about heart failure biology. And part of the problem was that I had been a devotee of Jay Cohn, and I realized he's had a huge impact on heart failure in this community. And there was this consensus statement on cardiac remodeling. And he said that although remodeling is generally accepted as a determinant of the clinical course, slowing or reverse remodeling has not until recently been recognized as a goal of therapy. And for many of us, this was the holy grail. If you could reverse remodel the ventricle and improve the ejection fraction, you would cure the heart failure. And I fervently believe this, and so I just didn't understand the data that we were seeing, but we kept on seeing it. And then, of course, there were leading textbooks in the field that indicated that reverse remodeling was synonymous with resolution of heart failure. The problem was that I wrote every single chapter in these books. So the next take-home message is try to avoid not drinking too much of your own Kool-Aid. It can leave you really confused and hungover. So this required a kind of rethinking of heart failure biology. And so there was a time where I was at a Gordon Symposium with Dan Burchell, and this is when the LVAD mafia was really touting recovery and claiming victory. And Dan and I had a couple glasses of wine, and I looked him in the eye and I said, do you think recovery really exists? And he goes, hell no. So we went off into the woods the next day and talked about this, and that's where this initial JACC paper came out. And so we asked the question, is there something intrinsically different about patients whose hearts recover and they stay out of the hospital? These people clearly exist. And those patients whose hearts recover but are re-hospitalized with recurrent heart failure events. So there's a group of reverse remodeled. They stay free from events. So this refers to the myocyte, the LV, and the matrix. And they're a group of people who shuttle in between the two different entities. And so as a way to try to put some terminology on this, we said myocardial recovery should be usually referred to people who get better and never need a doctor again, whereas we think that most heart failure is a state of remission and that the patients will relapse and go in and out of heart failure. And Dan was comfortable with this, but was very uncomfortable with this. And of the two terminologies, this concept was actually more correct in terms of thinking about what was going on. So what are the biological determinants of myocardial remission? Does this entity exist? I showed you proteomic signatures, but what do we know about as doctors about what this is? And this is actually painfully obvious now with the retrospectoscope, but at the time, All the evidence was there, we just couldn't put it together correctly. So when I talk about remodeling, I think about changes in the myocyte, changes in the matrix, and changes in the geometry. All three of these collaborate during a reverse remodeling and improved ejection fraction. And I coined what I call the slinky hypothesis. This is just a simple way of thinking about what happens to the ventricle. Most of you, some of you probably have no idea what a slinky is. You're too young. But when I was a kid, there were these slinkies, and you could stretch them and then allow them to come back. And they were a lot of fun to play with. But if you had a tantrum, which I not infrequently had, and you stretched the slinky too far and then tried to get it to come back to its original state, you couldn't. So the slinky, once distorted, would never come back to the original shape or form or function. And I think the ventricle is a lot like a slinky that gets overstretched. So we had done some mouse studies, and as part of those mouse studies to show human relevance, we also went back into databases that we had, and we looked at changes in gene expression in patients who had undergone LVAD. So we had non-failing controls. We had LVAD samples before and after the LVAD, and we looked at changes in the gene expression, and we just compared the two. So if you come down to this group here, you can see that of the roughly 1,900 genes that are dysregulated in a heart failure heart, after LVAD support, most of them remain persistently dysregulated. They don't go back to normal. Small percentage do. Interestingly, there's also a new group of genes we called new reverse remodel genes that had never appeared before in heart failure, and there's a lot of recent research on what these genes are. If you then just go back to that PCA plot I showed you, the non-failing hearts are shown here, the blue are shown here, and then the green group, or the people who were LVAD supported, are somewhere in between. So again, this idea that with unloading and support, the heart partially comes back to normal, but not completely to normal. And if you just sort of break it down and try to understand what that means to the myocyte, for me, simplistically, when I think about myocyte, I think about the matrix. I think about how the sarcomeres are hooked into the matrix. I think about the sarcomeres. I think about all the calcium signaling apparatus. And I think about the energetics in the mitochondria. So if you just look at, we call these gene modules. If you look at the 5 different gene modules here, and you look at what's reversed, this column here, always on the right, is the persistently dysregulated. They don't get better. And the reversed ones are shown in this column. You can see a lot of white. The only genes that actually reversed were sarcomeric genes, and that makes sense because we saw some improvement in contractility. But the important point is that almost all of the critical genes that regulate the function of the myocyte remain persistently dysregulated. This is just a summary of this. You can see if you just look at the percentage of the genes that remain abnormal, heart failure status abnormal, and the ones that get better. The only ones, it's very 15%, 10% of the genes actually get better. So LVAD really helps reverse, but doesn't completely reverse. Really nice study by Armbedekar in Colorado. What they did was to take myocytes out of non-failing hearts, then before the LVAD went in, and then after the LVAD, and then they have the ability to take these myocytes, put them between 2 tweezers. They digest off the skin of the myocyte and then increase calcium in the bath. So these cells actually begin to develop tension, and you can measure the tension between the 2 different tweezers. And that's just shown here that the more calcium you put in, the more force they generate. So non-failing have about 15 millinewtons of force. The heart failure myocytes is significantly less, about maybe 4 to 5 millinewtons. And then after LVAD, they significantly improve. So LVAD does improve contractility. However, the important point is that if you notice, the non-failing is still much better than the post-LVAD recovered heart. So again, this concept that partial recovery but not complete recovery of function. If you just look at ultrastructure, again, this is work from Stavros Dracos, you can see the sarcomeres have this really nice crisp registration. These are non-failing. Before the LVAD goes in, you lose that registration, and you can see the mitochondria down here lose their cristae, so they get vague. And then after LVAD, there's a partial return of the registration. You can see it's fuzzy compared to the non, and the mitochondria come back partially. So again, with recovery, there's a partial restoration of the non-failing phenotype. They went on and did metabolism, and they showed that in the failing heart, glycolysis is reduced. That's been known for a number of years. And then after LVAD, although glycolysis improves, they still can't use the TCA cycle to generate energy. And a lot of the metabolites are shifted into sort of lactate pathways. So again, the concept that there's a partial restoration of function, but not a complete restoration. So what about myocardial alterations? And this has been a bit of a mess in the field with various investigators reporting different things. The bottom line is that most people, as opposed to seeing a decrease in the collagen content, which you would predict, most people see either no change or some slight increase. And part of the problem with the literature is it depends on what the background therapy is. Today, all LVAD patients are on sort of quadruple therapy, and we're beginning to see decreases in collagen, but a lot of it is really based on the background medical therapies that patients are placed on. And then the last thing was alterations in geometry, and this was also one of these things that I learned after I gave a talk and misquoted somebody. But the idea here is that in the dilated heart, it becomes like a basketball as opposed to a football. This creates de novo mechanical stress on the heart because meridional wall stress increases just based on the size. And when the ventricle gets smaller, it goes back to that football shape, and that means there's a decrease in the meridional wall stress. So just by reverse remodeling, you reduce the load on the ventricle. So this is really important. But there were studies in humans, and this is, Barboni came up to me after I gave a talk and said, "Did you read my study?" And I said, "No, I missed it." He deftly pointed out that what they did was they took human hearts, they then hung them in a Langendorf apparatus, buffer perfused them, and did LV pressure volume curves. So the non-failing are shown on the solid line here. Heart failure shifted all the way to the right, which Jay Cohn had shown years ago, not surprising. And then with reverse remodeling, after LVAD support, the pressure volume curves looked a lot like non-failing. As a heart failure physiologist, I would say this is victory. Okay, this is exactly what we want. But then what they did was they looked at long axis dimensions and minor axis dimensions and wall thickness. So the dimensions go down, we know that, but the interesting thing was that the wall thickness really never improved. It always remained abnormal. So the R to H, which is the radius to the wall thickness, a poor man's version of wall stress, the wall stress never normalized. So the fact that the hearts were smaller, the walls were thinner, and so now you've got a myocyte, the transcriptional program's abnormal, it's contracting better but not as well, and it can't normalize wall stress. Is it any wonder why these hearts are not doing well? So take a message number 4. Reverse remodeling is not a mirror image of the molecular and cellular pathways that become dysregulated during adverse remodeling. Rather, pardon me, reverse remodeling represents a coordinated multi-level process that allows the heart to adopt a new, less pathologic state that's associated with improved function, improved outcomes, but it's not normal. And that many of the changes that occur during forward remodeling remain dysregulated in reverse remodeled hearts. And that's the key insight. Although they look normal and they beat normal, they ain't normal. And just as a way of thinking about this, there's a theory of called biologic robustness. I was trained as a physiologist, so I'm used to homeostasis. I had no idea about how to put this in a biological construct. But what they think about robustness is that an organ can take a hit and then reorganize itself and then still function. That's a biologically robust state. So I think what happens in heart failure with a minor hit, you get pushed out. EF may drop transiently, but then you come back to a normal EF and a normal size. On the other hand, if you have like a large infarct or a sustained myocardial inflammation, you lose a lot of tissue, your EF goes down, comes back partially, and you occupy a different steady state. Both of these are robust responses in that the patient lives, stays out of the hospital more. But the important thing is it's not a normal heart. So I think recovery is probably more of a homeostatic response, whereas the state of remission really represents a different steady state. And I've tried to give you the biological underpinnings of that steady state. Basically, the heart halfway comes back, but these people still have heart failure. And this, again, got me banned from the LVAD symposia for 10 years. They now agree with me that it's remission. Anyway, so I think people are probably getting bored now, and you have concern that I have no intention of honoring Dr. Burchell and bringing this back to the bedside. So I'm going to sort of walk you through how these ideas actually played out. So there was this trial called TREAD-HF, and what they did, and I have no idea how they actually got this passed in IRB, is they took people with a recovered EF, they used a really rigid, stringent definition. EF had to improve, ventricle had to get small, NT-proBNP had to normalize, and then they took these people off of medical therapy and then followed them. And they defined a relapse as a decrease in the EF by more than 10%. I would have agreed with that. And the EF had to go down less than 50. Also, the increase in the LV-EDV by 10%, and there was a 2 times rise in the NT-proBNP. And what they noticed was that in the people they took off of heart failure therapy, they redeveloped heart failure. And I guess this should have been obvious at the time, but it was really, when I read this, I said, okay, so we're right. This got me re-invited back to the recovery symposia, by the way, because this was sort of unequivocal proof that the heart failure doesn't really recover. And you can see a lot of it was because the EFs went down and the ventricles got big, and the smaller group had an increase in NT-proBNP. And they said this finding suggests that for many patients, improvement in cardiac function following treatment does not reflect full and sustained recovery, but rather reflects remission, which requires at least some treatment to be maintained. And I think, although this is only 50 people, the smallest study ever in heart failure, I think it does point out that these patients remain vulnerable to recurrent stress, and that's why they're coming back in the hospital. So the recent heart failure guidelines, which were chaired by a group of people, including one person I trained, who I just love, Dr. Boskert, they decided to do away with recovered and use the term improved because they said the heart doesn't really recover, and that's just going to confuse the heck out of clinicians. So they came up with improved LVEF. Their definition said that there had to be an EF less than 40, which we agreed with, but the follow-up had to be greater than 40, and they didn't really put a number on it. And this is where I disagree a little bit, because you could have an EF of 39 and then go to 40, and to me that's not really recovery. And they did emphasize the assessment of ejection fraction. But the important thing is that this became now a new entity of patients that were going to require new guidelines. And so this is just sort of from the current guidelines. They think about heart failure, a reduced ejection fraction. It can remain depressed or it can improve. And they say that in patients with improved EF after treatment, guideline-directed medical therapy should be continued to prevent relapse of heart failure and left ventricular dysfunction, even in patients who may become asymptomatic. And so this, I think, was the first time that this group of people actually had a nomenclature and had recommendations, albeit really on not a lot of data. Fortunately, there have been some studies now. This was from the DELIVER study, and to get into DELIVER, you had to have an ejection fraction greater than 40%. They were interested in using dapagliflozin in people with the mid-range and preserved EF, but they did have a pre-specified analysis. If you had an EF less than 40 in the past, and you were 40 at the time of randomization, you could get into the study. So the preserved EF, previous EF less than 40 are shown in blue, and the previous EF greater than 40 are shown in purple. And if you just look at the primary composite, which was CV death, heart failure hospitalization, unexpected heart failure events, both groups do well, but importantly, the group that had improved their ejection fraction did benefit. And then if you go down the line, CV death is improved, worsening heart failure not necessarily, all-cause death no, but the composite of CV death and heart failure events is improved. So this was the first indication of a class of drugs that we knew was relatively specific for heart failure improved EF. Where I have a problem with is, that, again, they could have had an EF of 39, and it could have been 40 at the time of randomization, and anybody who reads an echo knows there's a 5% variability. Nonetheless, this is the first study that we have. TREAD-HF, Brian Holliday did a nice analysis of what happened when you took away loop diuretics, mineralocorticoid receptors, beta blockers, ACE or ARBs. ARNIs weren't around then. And they noticed that in the control subjects who were on meds, heart rate didn't increase, but as you began to withdraw standard guideline-directed medical therapy, you could see that the heart rates began to increase, and those who were withdrawn that didn't relapse had lower heart rates than those who withdrew who did have relapse. And I actually spoke to Holiday over the phone, and I said, among the drugs that you have, which one would you want patients to stay on last and not have removed? And he said, beta blockers, of course. And I think this semi-supports that point of view that beta blockers are really an essential mainstay of therapy because they're blocking the sympathetic nervous system, and probably based on the results of the sub-analysis from this study, probably SGLT2 should also be core therapy for the improved EF group. So the interesting part is that the heart failure improved EF, not surprisingly, are extremely heterogeneous. And this is the fun part because probably there's a group of people who, within that bucket, don't really need to see a doctor, and then there are a group who will. So Barry Greenberg did a really nice analysis. We had previously shown that at the time of recovery, if your global longitudinal stress is less than 16, you're more likely to redevelop heart failure. They did a much better analysis and job of this, so I'm just going to show his data. But you can see here that at the time of recovery to an EF greater than 50, that the global longitudinal strains range from very low to very high and normal. They used a median cut point of about 12%, and then notice that if you recover your EF and your strain is greater than 12, or greater than minus 12, you do well. If it's less, you develop recurrent heart failure events. And again, that's not surprising because this is probably just teasing out those people who have more end organ damage. So again, the concept that this group of people, we don't know how to define them yet, other than just the EF being better, but they're probably very heterogeneous. We did a study, again, with one of the medical residents. We used machine learning to just sort of, we had 1,000 patients, all of whom had improved their ejection fractions, and we just turned what they call unsupervised cluster analysis on trying to identify groups of people who didn't do well, and came up with a number of different clusters. The problem with this is it'll lump an ischemic in with a dilated with a group of women. So it's not a specific cluster that we as doctors can recognize. But the interesting thing was that if you look at the different clusters, you can see there's a spectrum of clinical phenotypes that will drop their EF. This group here had wide QRSs. We couldn't get out of our database whether it was left bundle, right bundle. Everybody who needed a CRT got a CRT at our place. But this is probably wide QRSs driving this. And we know that nonspecific wide QRS is also a marker for a myopathic process in the ventricle. So I think in the future, we may be able to define clinical phenotypes. We also looked at mortality in the different clusters. And you can see, again, the group of people who had these wide QRSs, less than 0.15, but sort of wide nonetheless, they died more rapidly. So again, the concept here is there are probably clinical phenotypes that we can pick out and define who will probably need more intensive therapy and those who probably don't need intensive therapy. And then the last thing, and this has become really abundantly apparent, is that genetic variants will also predict who recovers and who doesn't, and also the fragility of recovery. So there was a really nice paper from a Spanish group of investigators. They had 20 different centers in Spain, and they genotyped everybody with dilated cardiomyopathy. And they found that about 50% of the patients who were genotype negative for the classic genes got better, and that's pretty much standard in the literature. But depending on the type of genetic defect that they had, some didn't recover, some did. Desmosomal mutations didn't. The nuclear envelope, the lamins, these are really awful patients to take care of because they just get sick. You can see here that Titin, which is the most common gene mutation, they get better. But now there are studies that sort of over time, this is the group of people who are also beginning to come back in the hospital. So you can have a genetic defect and get better, but that doesn't mean that you're better for life. So again, this concept that the genetic makeup may also influence recovery, again, just pointing to the fact that things are heterogeneous. So just bringing this back to current recommendations, the current society guidelines are that if your ejection fraction despite being on the 4 pillar therapies at the right doses, that's the key thing. If the ejection fraction remains low, that the current guidelines are, or is improved rather, the current guidelines are that you remain on guideline-directed medical therapy indefinitely. I think this is going to change as we begin to understand who needs it and who doesn't, but we're not there yet. And then obviously if your ejection fraction remains depressed, you can go on and do different therapies, including CRT and things like hydralazine isosorbide. Again, this is, I was just happy that this entity got recognized and that there are now guidelines for this. So just to bring this back in honor of Dr. Burchell and just try to make this clinically useful, I think the first thing to recognize is this group of heart failure improved, they're heterogeneous. Right now we treat them as one bucket. I think that's going to change over time. But I think for today, leave them on guideline-directed medical therapy. We really understand very little about which medications are required and which medications can be withdrawn. And as I said, the DELIVER trial with dapagliflozin showed that that group of people does do better on an SGLT2 inhibitor. Based on the results of the TREAD-HF, and I got to emphasize, this is 51 people. Never did I thought I would be making a recommendation on 51 people. They recommend a continued guideline-directed therapy in all patients. And the reason for this really is that relapse of heart failure, when you get sick again, you start leaking troponin. So you're nibbling off on myocytes. Each time a patient comes back into the hospital and the tropes are high, you're just killing off more and more of the heart. So you really want to try to prevent the relapses. We do think that you can withdraw diuretic therapy or consider it because they are toxic overall to the kidney. But if heart failure recurs after withdrawing, consider up-titrating the guideline medical therapy. So this is the only one that I think you can back-titrate when patients become stable. And then lastly, I want to say that there's really nothing original in the world. We've probably known about remission for a long time, just never put a fancy word on it. This is a really nice slide from Desai and Stevenson where they talk about readmission rates. There's this initial high readmission rates with patients when they initially come in, then they stabilize, and then at the end they come in, need VAD transplant or hospice. And this is probably this process of forward remodeling, the hearts are dilating. Today we know that at least for HFrEF, that the stability is attended by reverse remodeling and improved EF. And as I showed you, it's really, we don't have a cure for this disease yet, and so ultimately all these patients are probably going to deteriorate for reasons that we don't really understand really well at this time, and they'll come back in the hospital and need advanced therapies or hospice. So why should you care about this as clinicians? And this is where I think we as a community need to rise up and storm Congress. Not January 6th storming Congress, but maybe something a little bit more muted, because Scott wouldn't look good in one of those buffalo hats. But so the way that the Central Billing Office figures out what we get reimbursed for and what we don't get reimbursed for is it's called Does It Score? Is it saving money for the taxpayer? And so, as you know, heart failure readmissions were ascribed to poor care, bad doctors, and bad healthcare systems. And now we all get punished for it. So there was this recent study that looked at trends in readmission, and because of the financial pressures, hospital systems are now keeping these people out of the hospital to avoid getting penalized. But you can see that mortality now is trending up. And so if this really is remission and these people are really sick, what they need to be is back in the hospital getting good medical care rather than not in the hospital. So I think our way of looking at this is really backwards. And I think it has to come from the medical community because there have been studies now. This is not bad care or bad doctors. This is just a bad policy. And unfortunately, we as a community have not pushed back enough on this, but we need to. So with that, I want to thank you for giving me the opportunity to present the Burchell Lecture. He seems like a remarkable person, and I'm just glad to be able to honor his memory today. Thank you.
Okay, that was questions. I knew there would be a lot. Jay?
Doug, thanks so much for that great talk. Did you have many peripartum cardiomyopathies in your database, and are they pretty typical?
Yeah, so that is a really great group of people. We didn't have a lot of peripartum in ours, but Dennis McNamara, as you know, has done a lot of work on this. And I think that the reason why a lot of these women develop myopathies, they probably have underlying asymptomatic type mutations, and that's actually been shown by the group at Penn. And then when they get stressed, obviously they develop a heart failure phenotype after they deliver just the stress on an underlying substrate that doesn't stress well because of the type mutation. And then not surprisingly, that group of people will get better after the inciting stress is removed. There's still a group of, there's the whole bromocriptine story, which is contentious, and Dennis is doing a trial now with that to show that the bromocriptine story is probably not an issue, because that means that women shouldn't breastfeed their children because they're going to redevelop heart failure. So I think that's a really interesting group of people. I think a lot of it is going to be a genetic abnormality that gets unmasked during pregnancy, and you would predict that they're going to recover. What we don't have is really good longitudinal data to know once they get better, do they need to stay on medicines. You can imagine a 22-year-old mom is not going to want to be on 4 pillar therapies while she's chasing a toddler around the house. So we need to do better, but we didn't have a lot there. But Dennis has the best data set, and he's beginning to sort of unpack that.
Peter? Thanks for a great talk. I'm wondering how you follow these patients clinically. If you have someone that their ejection fraction improves, do you say, get an echo every year? Do you say, go back to your primary and come back if you have problems? How do you manage them?
Yeah, so we in the JACC article, and I took it out of here just to save time, we recommended that first year that they recover, they be seen at least twice, that they get an echo at the 1-year time point, and they be followed with coming back to clinic, seen by a heart failure or cardiologist, and getting NT-proBNPs during that first year. If they maintain stability after that first year, we think you could go out to annual evaluations. We don't just put them back with the internist. As I said, we continue to follow the people and have open discussions with the patient that we're still in the infancy of understanding this, but we don't cut them loose. We do hold on to them and follow them, because I do think they remain at risk for redeveloping heart failure. And as I said, it's a vicious spiral downward. Each time you have acute heart failure, you're losing more and more myocytes. So at some point it becomes ineluctable. You cross the Rubicon and you don't get better. So we hope that stabilizing these people, you prevent them from developing intractable heart failure. How do you guys do it here? Do you just...
I think we tend to keep seeing them, but there's a lot of people that come back and, you're here for your annual near normal echo, and at the same time, the Visigoths are at the border with, there's plenty of other new patients that may have a more urgent need. So I struggle with how much do I need to keep seeing them versus get an echo and come back if something changes.
Yeah, I think you could, NPs could easily, I think they ought to be followed by people who understand the fragility of the new steady state of improved EF. Again, it's heterogeneous. If it was a postpartum, they may never need to see a doctor again. And there are groups of people like Takasubu. I don't think we really know, so I don't think it should be hard and fast. But if it's somebody who had an EF of 30%, who's now 45, I don't think they're cured. And I do think being followed. If it was somebody who had an EF of 35 that went up to 40, and that 35 was in the setting of acute ischemia, and then they get better, that's maybe a different patient. And there's where MRI can help you too. If they've got a lot of LGE on the MRI, I probably would continue to follow them, because that's going to be a nidus for things.
Yeah, great talk. Really enjoyed the highlighting one of the aspects you mentioned about the heterogeneity in these phenotypes. One thing that was missing to me actually was the involvement of the right ventricle. Maybe echo is difficult to assess that, but how do you see that playing? And a quick second one is, how do you see also these new technologies that are producing reverse remodeling mechanically? Like the core cap that you work with, or the AccuCinch?
Yeah.
Is there
so I'm a device geek, have always been. And I think that what he's referring to is there are now a number of devices that can either cinch the ventricle. I think the best we have right now is the MitraClip, because that's allowing for reverse remodeling. And there's a clear argument for guideline-directed medical therapy and a device. I think there's room for the devices. Where they're going to fit in, the problem is that heart failure improved group, it's really hard to do a clinical trial on them because their event rates are a lot lower. So we tend to put in the devices in the sickest group of people rather than the people who may benefit the most in stabilizing it. So I don't have an answer to your question. The right ventricle remains a mystery, and we discussed that in the writing group. We don't have really good data on these people, and it's a really interesting question to see whether there are echo data when you do reverse remodel. Presumably your pulmonary pressures would go down and the right ventricle would follow, but I can't actually tell you I know a study that's looked at that, and that's a really great question that's an area that I think is still open. I'm assuming that you wouldn't ever feel better or recover if your right ventricle is completely blown out, but I don't have data that I could point to and say this is right or wrong.
A wonderful talk, thank you.
Thank you.
In trying to sort the group that really got a lot better,
Yeah.
In doing MRI, and we see a lot, we can get relatively accurate volumes, we get ECV, we get global longitudinal strain, also the issue of delayed enhancement. And when you look at all of these parameters, in your sense, is it truly volumes that put you in the right category? Is it everything together? How do you weight that?
Yeah, I think, so to me, again, this goes back to my training at San Diego, which was old ventricular mechanics. I think that if the myocyte can't shorten normally, and you have a ventricle that has been disrupted in some way, I didn't get into it. We tend to look at collagen as the amount, but I think the collagen is a lot like Spanx. And in other versions of this talk, I talk about Spanx. But I think that when Spanx gets stretched out, it never comes back to the original length. And I think collagen's like that too. So although the ventricle may get smaller, the tensile properties of the collagen are still abnormal. So if you eat a bag of potato chips, you're more likely to dilate. So I think it's a combination of the myocyte not being able to withstand a stress. If your shortening is 10% longitudinal strain versus 20, the 10% myocyte's not going to take a hit as well. And then you combine that with other abnormalities in the ventricle, and I think they just dilate up again. So I don't think we have a great measure that unequivocally says this person is normal. I will tell you now there are two studies, one from our group and then Barry Greenberg's analysis on strain and looking at who does well and who doesn't well when the EF recovers. And again, this makes intuitive sense to me that you can get the heart to get small again and ejection fraction to improve. But if the underlying myocyte is not doing well, those patients, they're more vulnerable. They get tachycardia, they get one bout of ischemia. They're more likely to deteriorate and come back in the hospital.
Thanks again for a great talk. My question is on revascularization. We revived, showing no benefit, statistics shows benefit. What is your take based on genomics or other parameters?
Yeah, I was afraid you're going to ask that. So how many interventionalists are in the room? Okay. I'm leaving. Here the plane's coming. No, I think, so the guidelines, which I agree with, I think if there's angina and the patient can withstand surgery, the data from Stitch would support complete revascularization. I was one of those people who went with angioplasty first rather than surgery just because the patients, to me, they would recover better. What we know today is that ischemia in dilated ventricles may not be what's driving the heart failure phenotype. It may not be mechanistically involved, but if it's affecting patient quality of life, then we would do either revascularization surgically or with a PCI just based on standard ways we take care of heart failure patients. But a lot of people have fished in that pond and tried to look at the whole viability question and defining, if they have viable tissue and a lot of viable tissue that when you revascularize it, they're going to get better. We've not been able to prove that. Now, having said that, I think definitions of viability vary from institution to institution. If you're in Canada, you know how to define it. If you're in the US, you don't. But so we may not have the instruments or the tools yet to show that ischemia is important. But obviously, I think if you're having recurrent myocardial ischemia and nibbling off myocytes, that's not a good thing either. It's just that the data are strongest for revascularization surgically, CABG, but you have to be alive for at least 5 years to see that benefit because of the upfront costs. So I think the guidelines are that if you have angina and suitable targets, that you get revascularized. But it has to be driven by angina, not just by a bad ventricle that has low FFR, right? Because they're not going to get better, right? We know that.
Fantastic talk. Can you comment a little bit about the risk for ventricular arrhythmias in remission?
Yeah. So this was an area. Do you let's say the patient comes in, is doing well on guideline-directed medical therapy. They had an ICD in, and now you got to change the generator. And EF is 45%. What's the insurance company going to say? They're going to say no, of course, right? Where we came down on the guidelines is that person still has high-risk substrate, that it's not a normal ventricle, and that you ought to renew or change the generator. Now, that's different than putting an ICD in somebody who was 35, is now 45, and coming to your clinic. I don't know that we have data on that because there's never been a trial on those people. But I think the substrate and the nidus for ventricular arrhythmias is still there. I don't know how much of it gets better, but just knowing what I know about heart failure and how messed up these ventricles are, even though the EF is normal, I think that there's still high risk for events. And so I would renew their generators. And there was a study that came out and supported what we put in the JACC paper too. All four of us on the paper on the writing committee, Jane Wilcox was the strongest on it, but she felt that we know so little, and the ventricles don't get better in terms of the whole substrate that you ought to at least replace the generators when they come back in. Yes, sir.
As an electrophysiologist, we also get excited when we see that ejection fraction improve. You mentioned the tachy-mediated cardiomyopathy patients do really well. We also see super responders from CRT.
Yes.
And I was wondering how you would categorize them. Do they look more like the improved ejection fraction, or do they look more?
We don't have proteomic analysis, but it's really clear that in a group of people, and Jane was a big one on super responders, I don't think we understand why they're super responders. The simplistic answer is they have more myocytes to recover, and there's less end organ damage in those people, and that's why they bounce back. It could just be you got the lead right, and you tickled the conduction system in just the right spot. But there's really a group of people who get significantly better, and we see that on medicines too, right? There's some people who on guideline-directed medical therapy, the EF just comes up within a period of 3 months. It's not this niggling, naggling 6 to 9 months, improving by 2 to 3%, but they'll just get all better. So the simplistic answer is I think they probably have less disruption of the underlying architecture, and therefore they're more likely to come back to normal.
We're also very interested in that genetic population. What accounts for the heterogeneity there? Is it some of the genetic mutations can behave more inflammatory, or some of them more in a different mechanism?
Yeah,
why is that?
I think, so the answer is I don't know. I think anytime you get cell death, you're going to get inflammation. So I think when you're like on an ARVCD, I think you probably have a lot of cell death in those patients. That's why you're getting a lot of inflammation, and that again, drives the disease more. The lamin mutations, for whatever reason, I hate taking care of those patients in clinic. They just never get better. We don't see a lot of desmosomal mutations at WashU, but we do see a lot of lamin mutations because they'll also get neurologic stuff. So they come into the system, and we see them more often. I was really struck with the tight mutations. I would have predicted, based on the location in the sarcomere, they wouldn't have gotten better. And again, I also predicted that CRT wouldn't work, and I also predicted that George Clooney wouldn't last more than a year on ER. So I don't go to Vegas, okay? But there are certain groups of the genetic cardiomyopathies that do get better. But as I said, now there are data beginning to accrue that they also will develop recurrent heart failure.
Yes, we do have two online questions. I know we're a little past time, so maybe we could just quickly go through these. But the first question comes from Dr. Dirks, who asks, how much does getting people on goal therapy quickly affect long-term outcomes?
Yeah, so there's currently a huge push in the heart failure field to get people on quadruple therapy as quickly as possible. The arguments for that are that if you wait longer, that you're more likely to get recurrent heart failure. The difficulty I find with that, and a lot of these are what I call talking heads. They're not people who necessarily take care of patients anymore. But if you try to put somebody on 4 medical therapies at once, oftentimes they get symptomatic. You don't know what's causing the symptoms, and the patient's less likely to trust you ever again and go on any medical therapies. So I think we don't know how to sequence increasing the doses. I do think the thing that most cardiologists make the mistake on is that they think that getting them on guideline medical therapy is the same thing on getting them on the right dose. And I think anybody who's taking care of a heart failure patient will tell you that as you get closer to that ceiling dose, patients begin to feel better. But it takes time to get people there where they don't get symptomatic. And my concern with our rush to do this right now is that you're going to make people symptomatic and they're just going to go, I ain't doing this, doc. You make me feel like crap. I have no energy. I feel awful. I'm lightheaded. Whereas if you actually do it gradually, you can get patients who never have symptoms, but you can get them all on the guideline-directed medical therapies. We need to do a study on this, but I'm saying that the dictum today, guideline, the recommendations are get people on quadruple therapy as fast as possible. The guidelines are agnostic about the strategy, but the ones that I've seen proposed, so SGLT2 inhibitors don't drop blood pressure, and MRAs don't really drop blood pressure. So I start with the 2 of those and try to get them up fast, and then sneak in the other drugs more gradually, because I can do it without making the patient symptomatic. But you have to be careful to build trust with the patient. So and I tell them, I said, look, I may make you feel crummy, just give me a call, we'll back titrate. But it has to be an open dialogue versus we're putting you on this, and if you get symptomatic, that's your problem.
Yeah, absolutely. Thank you very much for that. So the last virtual question we have, apologies if you did cover this, I believe, in one of your last slides, but the question comes from an anonymous attendee, and they ask, in young patients with tachycardia-mediated CMP and normalization of EF, do you recommend continued medical therapy?
So there is actually a paper on this, and it was in younger people, and they found that when they stopped the diuretics, I think like 30%, 40% actually got worse. I think that, so the most important thing is if the patient wants to come off of medicines, you have to have a discussion with them, risks and benefits. I feel less concerned about stopping medicines in those people, but I would follow them, maybe see them quarterly, as opposed to seeing them every 6 months, and just get serial NT-proBNPs on them. But there are a certain percent of people who don't need medical therapy, but there's actually an older paper where they follow those people, and they noticed that when this is back in the digitalis era, and so we also know that if you take people off of digitalis, they develop recurrent heart failure. But there's at least one paper that shows that 30 to 40% of those people do develop recurrent heart failure symptoms. So it's not 100% or out of the woods.
Well, I think Dr. Burchell would be smiling on us right now. So it's just a fantastic lecture. Thanks to Behringer and AstraZeneca for support, and thanks to you guys for coming. And Dr. Mann will be here for a few hours, and we'll look forward to next time and more answers.